what makes me optimistic now is the fact that we are able to openly talk about racism.
This year, for the first time, we had more doctors from ethnic minority background on our register than white doctors.
I think regulation can be a force for positive change.
There is a danger in the narrative about UK trained doctors that we send a signal that somehow doctors who've trained overseas are less welcome, that they're not valued. The 10-year plan as a massive opportunity to make progress on this agenda.
What kind of society do we want to live in? It needs to be a society where people are able to engage with each other, able to celebrate their differences.
I've been really heartened by the extent to which our valued 3,000 staff in CQC are all determined to really drive that patient-centred agenda.
Success of the plan will depend upon the degree to which we are able to, as collectively, build and rebuild levels of trust with our communities and with our staff.
No single organisation can fix inequality in isolation.
Voices of Care, the healthcare podcast.
Julian, Habib, Charlie, welcome to Voices of Care again. Great to have you on here. A seminal moment for the NHS. 10-year plan, of course, has been published a while back now. And we're here to really look at the workforce equality issues and really highlight some of the work that you've all been doing. I think you had a roundtable event back in June in the summer where distinctively you came together as regulators to discuss this point. Julian, can you tell us a little bit about that? Because it's quite a distinctive gathering.
Yes, absolutely. And great to be here. It was, I felt, as you say, quite a seminal moment in terms of regulators, providers, system leaders coming together, really to look at the issue of tackling workforce race inequality in health and social care. And we were delighted that the GMC, NMC, ourselves came together, and under the chairmanship of Habib and the Race and Health Observatory, we looked at some of the key questions that face us right now. I think the evidence base for this is compelling in terms of the impact of inequality across the health workforce and the ultimate impact on delivery of care. There's a really clear agenda for providers of care, but also I think for regulators, because ultimately I believe one of the roles of regulation is to spur improvement, development, awareness. And certainly in the session we had, which was very positive and productive, we considered both the research and evidence and also some of the practical action required of us as regulators of the system in order to address what is a major issue. And I'm sure as we talk through it today, we'll highlight some of the key issues, gaps and action that we need to take.
No, absolutely. And Charlie, from the GMC's perspective, I think at the roundtable, you were candid as ever, saying that the price of getting this right was worth it. It's not an overnight fix. And I think you highlighted the fact that it's rare that potentially one can move the dial on that mythical productivity that's always talked about without actually necessarily investing large sums of money if we get this point right.
Yeah, that's absolutely right, Sahel. So I think, the fact is that our most important assets in healthcare are the healthcare professionals who work within it. And the fact is also that we know that too many of those healthcare professionals face inequalities in their day-to-day work in medicine. I mean, our focus is doctors as the General Medical Council. This year, for the first time, we had more doctors from ethnic minority background on our register than white doctors. So that's a really important tipping point. But at the same time, we know that we see inequality that is both prevalent and pernicious.
I think you use the word shameful.
It is shameful. It is shameful. And your point around productivity is really important, because that inequality means that doctors aren't able to perform at their best. It means we're more likely to lose the capable doctors that we need. But I think the key point for me from the roundtable was that real collective understanding that the whole is greater than the sum of its parts. Healthcare is complex and it's interrelated. No single organisation can fix inequality in isolation, and of course we'll all focus on our own responsibilities. But the scale of the challenge requires collective commitment, and my very strong belief is that if we align our efforts, we're going to have a much better chance of success. If we're clear about our expectations from professional regulators about what standards we expect from the healthcare professional that we regulate, if system regulators are really clear about expectations from employers, providers and systems, and if those align, we have a much better chance of succeeding.
And hence the reason to bring the regulators together. Now, the first step, of course, is identifying the challenge. And Professor Habib, you presented some data. I hate to remind everybody, it's, I think, something like 10 years since the Workforce Race Equality Standard began producing data, some interesting insights, but perhaps you can flesh out a little bit about the data that you shared and what the data tells us around the diversity of the NHS workforce, because it's dramatically changed in recent years.
And is continuously changing. The data tell us that tackling inequalities is critical for health and across the healthcare system. As you say, Sahil, 10 years on from the rollout of the WRES, we have made some progress in some areas, but there's a huge amount of work to do to look at representation, to look at the experience of ethnic minority staff working in health and social care. And it's by no means mission accomplished. And just as Charlie has said, over 50% of the medical workforce is from an ethnic minority background, and that kind of highlights the dependence we have on international recruitment and international staff, and other parts of the workforce, nursing workforce, etc. And that diversity is fantastic. It's great and needs to be celebrated, and it must be celebrated. And at the same time, the healthcare system and the NHS must be ready for that level of diversity. And the data tell us that it's not. The statistics we have around bullying and harassment, discrimination from your own colleagues, twice as high for ethnic minority staff compared to their white counterparts, more likely to go through a formal disciplinary process than their white counterparts. And of course, leadership representation remains problematic for the NHS, is a long-standing challenge for the NHS. I remember back in 2021, the gap between board representation, workforce representation for ethnic minority staff was around 9%. That since 2021, that gap has grown to 12%.
Despite the EDI plan coming out in 2023.
Absolutely. Yes. So there's a huge amount of work to be done in this area. And of course, tackling these challenges is critical for the NHS and critical for the 10-year healthcare plan to be successful. You know, these challenges are not distinct to the issues that we have or the challenges that we have around health inequalities, and making sure that the NHS is equitable for everyone.
Absolutely. And Julian, I remember, I don't know if you remember, but it was on a fairly wet afternoon in Leeds. We met just after the interim people plan was published, which you had a big part in, of course. And now 5-6 years on, you took the bull by the horns, in a sense, around this round table and commissioned some distinctive research from the Institute of Employment Studies, I think, which revealed the extent of the lived experience of people across the system.
That's absolutely right, Sahil. And that was an important piece of research, and obviously will inform our work as a regulator. But the research essentially looks at the unfair treatment of workers in health and adult social care. And we wanted to understand how discrimination both in the system and between people affects staff, and the best way to stop this unfairness by using regulation. And I think this really matters because we wanted to learn more about that unfair treatment. And that includes how people might be treated unfairly because of workplace rules, culture, or indeed wider society. And we wanted to find out how practically we could reduce that unfairness by using regulation. Because I think, as I said, I think regulation can be a force for positive change, as well as obviously, certainly our key role in protecting people that use services. There's always a really strong connection between the experience of frontline staff, their experience of leadership, their experience of the culture of the organisation, and ultimately what patients, people that use services, those that draw on health care and social care support experience. So the consequence of this is that it's really helping to sort of shape our approach as we think about refining and improving our assessment framework. The CQC has been heavily criticised around the single assessment framework, and we're determined to improve that. But what better way than to start with some compelling research that adds to the body of research and evidence, so that when we look at organisations and we look at systems, we're focused and sensitised, and our inspectors and our teams really understand the impact of this. I would also add, of course, that we're delighted that we've got 4 new chief inspectors. And in terms of that broader focus on health inequalities, our new Chief Inspector of Primary and Community Services, Professor Bola Olawabe, will be bringing a huge amount of experience and insight to that. So I think just in terms of turning that research into practice, I think we're feeling positive, determined, and energized by that.
No, and that's good to hear. In terms of, as you say, the CQC has been on a journey prior to your taking the helm. You obviously don't like easy wickets, so it's great to see that. One thing that struck me from that research from the Institute, Professor Habib, was that I think 80% of respondents highlighted their lived experience of feeling distressed, but only 25% felt confident enough to raise it formally. Some of the metrics or some of the recommendations that you shared might be quite important to highlight here, because there's a training issue here for leaders and individuals. If we're having these type of recurring numbers, broadly speaking, over the WRES data, with, as you said, Black, minority, ethnic staff twice as likely to face discrimination from a colleague.
Yes, absolutely. And just as Julian has highlighted, there is an evidence-based link between staff satisfaction and better outcomes for patients. And the research tells us that the way an organisation treats its staff, and in particular its minority staff, is a good barometer for the overall culture of care within an organisation. But we also know from previous reports, the Francis report, for example, that ethnic minority staff are less likely to speak up because of the fear of speaking up.
Yep.
And so we have to get the culture right. And you know, regulation plays a key role. Accountability plays a key role in shifting the dial of inequality so that we have fair workplaces that lead to better patient experiences, better patient outcomes, and patient safety. You know, these are critical issues for the NHS.
Moving to slightly broader context, so staying with you briefly, one of the drivers of this inequality of experience from the research that the CQC commissioned was the wider inequality that we're perhaps seeing in rhetoric and reality in the UK. It's something that is at least germane to this conversation.
Well, racism is a global system-wide challenge that requires a global system-wide response. You know, we in the NHS, we have 1.5, 1.6 million people working.
30% from minorities.
And increasing. So when I started working on the WRES, it was 1 in every 5 members of staff across the NHS from an ethnic minority background. Today, that's 1 in every 3 and increasing. So it's really critical that we focus on this agenda and we get it right, because those people that work in the NHS are part of our communities. The NHS, the healthcare system, is a microcosm of what happens in wider society. And so we cannot work, yes, the NHS has a role to play in tackling inequality, but it cannot be the only enabler. So we need to work with our partners, regulators, and beyond the NHS in order to tackle these, deep-seated, deeply ingrained, deep-seated issues.
Absolutely. Well, we've had, of course, the publication back in July of the 10-year plan. Charlie, if we can talk to that on a high level for now, what you see in it in terms of encouragement or otherwise on this particular issue. It says very unequivocally the NHS is going to become one of the best employers and the best experience. There'll be fewer staff in 2035 than the previous workforce plan suggested, but they'll be far better treated is the exact phrase.
Yes, and I think we all need to see the 10-year plan as a massive opportunity to make progress on this agenda, and indeed the 10-year workforce plan that we expect to follow towards the end of the calendar year. And I think it does give us a chance to really hardwire that focus on equality and diversity in a way that we haven't before. And I think particularly about how we measure and assess the performance of providers. And I really welcomed one particular aspect in the 10-year plan, which was a reference to creating new staff standards and to collect data on those and to use those data as an early warning system. I think one of the things that all of us in regulatory roles will recognize is the enormous power of data in shining a light on where things may be going wrong, but also where things get better. I mean, just to the earlier bit of the conversation, we've seen exactly the same sorts of things that Habib described in terms of doctors being referred to the GMC, ethnic minority doctors being twice as likely as white doctors, overseas trained doctors 3 times as likely. Yet the work we and others have been doing over the last few years means we're on track to eliminate that disparity. And so I think we need to use the 10-year plan to drive that. Your point, Sahel, about the plan saying there will be fewer staff than were previously planned in 2035, nonetheless more than we've got now. But I do think that also creates an opportunity to really recognize that making progress on this agenda isn't just because it should be a moral imperative, and it absolutely should, but also because it is so fundamental to productivity. If we're not allowing staff to fulfill their potential, if we're creating risks that people will leave the NHS, that is baking in a loss of productivity that we have to avoid if we're going to meet the aspirations set out in the 10-year plan. There are risks too in it. I mean, I think there is a lot of ambition in the 10-year plan. Personally, I think that's something we should welcome and try and support and try and think about our own individual and organizational roles in meeting that. But there is also a backdrop of significant cost pressures, and one of the challenges we've all faced in the past is that this agenda can feel like a nice to have rather than absolutely kind of essential underpin to all of our ambitions. So I think the kind of action that we've been taking together should signal very clearly this is fundamental. This isn't a kind of nice to have, kind of optional extra. And so I think the 10-year plan in summary gives us kind of an opportunity to make inclusion kind of mission critical to the success over the next period of years. And I think it's something that we as regulators have the opportunity to really reinforce is everybody's job. It's not just our job as regulators, it's not just employers' jobs. As employers are not just doctors' jobs in terms of what they do, it's everybody's job. Everybody needs to treat this as being absolutely fundamental to delivering great patient care.
Absolutely. And I think the patient sits at the heart of everything, regulation-wise, operation, delivery, provision. Julian, no pressure, but the 10-year plan talks about the CQC becoming the most effective patient-centric healthcare regulator in the world. So tell us a little bit about how that's going to happen.
Well, indeed. So, I mean, I think it's been well documented, the scale of the challenges that the CQC has had, the coming together of 3 major problems in terms of an assessment framework that has met with a lot of criticism, and together with a computer system, a regulatory platform that has failed, as well as a move away previously from the sort of sector specialist approach. Now, those 3 things together really did, I think, bring CQC to its knees, and I think now sort of famously Secretary of State declaring it not fit for purpose. So to go from that point to exactly what you've described in terms of a world-class regulator is going to take an awful lot of hard work, but it's a very, I think, exciting and doable journey for us to move along. And already, even over the last few months, I've been really heartened by the extent to which our valued 3,000 staff in CQC are all determined to really drive that patient-centered agenda. We've spent a lot of time working on our own culture within the organisation because, of course, when you're a provider, when the CQC comes to review your services, make assessments, inspect, that needs to be a process of reciprocity, learning, one where there is that real focus on the experience of the patient, of people that use services. And so we've reframed our purpose as a regulator to emphasize the fact that we have our core duty to protect people that use services, but we also have, and it is enshrined in the Act, we have a responsibility to support improvement. So the role, I think, of any regulator to highlight best practice, to bring people together, to ensure that everyone is clear what good looks like. And so the agenda we're talking about today is central to that. And as we move along through the changes we're making, so back to that sector expertise with our 4 chief inspectors that we've appointed, I'm delighted with the quality and the diversity of colleagues at that senior level. That's going to, I think, send a positive message about our intent as a regulator, the work that we're doing to reshape our assessment framework, and indeed the way that we're engaging with the service, both in social care, independent sector, NHS, primary care, to try to get colleagues out there involved in our work. I think the more that regulators have a strong connection with those they regulate, the better for both ultimately. Yes, of course, there will always be those examples where we need to intervene, where the most egregious, shocking episodes, but that's about us having an intelligent surveillance of risk. Back to the 10-year plan, use of artificial intelligence, use of data, sharing data across regulators, ensuring that we've got that sort of ability to oversee what's happening.
And early warnings using AI.
Exactly right.
Yeah.
So that's the agenda for us. It's one that I think will help support the ambitions of the 10-year plan. And interestingly, one thing we're thinking hard about at the moment is how we make sure that, for example, in primary and community services, we're supporting the ambition of a neighbourhood health service in the way that we regulate, rather than perhaps in the past looking at sort of individual institutions through a sort of silo. That this has to be joined up, because what people that use services experience is sometimes the gaps between services run by different organisations, and that's something that we know the 10-year plan is demanding improvement and change on.
No, it'll be interesting for you to come back and update us on the CQC way. I know the work that you did at Leeds with Virginia Mason, etc. Professor Habib, just on the 10-year plan briefly, obviously you were on record to welcome it, etc. Just wanted to get your views, but at the same time frame, we've talked about how important addressing and tackling inequality and racism for the workforce is for the patient, for the system, for the providers, for productivity. I want to talk about some brass tacks and economics, because at the end of the day, the system is under pressure funding wise. Talk to us about actually how important this is from a economic and cost perspective, because there is work going on to demonstrate this.
Absolutely. And there are different cases or reasons for why the tackling inequalities agenda is absolutely critical. We have the moral case, we have the legal case, we have the patient outcome case, which is perhaps the most important. But there's also the financial case. And not tackling this agenda means that the NHS, the country's economy, is wasting so much money we're talking billions of pounds in terms of patient-facing costs as a result of not focusing on equity, in terms of staff costs as well. So there is a huge amount of kind of need to highlight that the constant drumbeat around the importance of this agenda. And when I go out and talk with leaders, organizations and systems, I highlight all of those cases, because it shouldn't be the chief exec or the nominated NED or the ED&I person within the organization that leads this agenda. And it needs to be, as Charlie said, it needs to be everyone's responsibility. And of course, the finance director has a key role to play in that as well. So, leadership, demonstrable leadership, data, evidence, and accountability are real key areas. And just as Julian was highlighting, the progress that CQC is now making, it's great to, and I'm delighted that CQC have adopted the 7 principles of anti-racism from the Race and Health Observatory as well, because from my experience, if there's one thing that keeps a leader or a chief exec awake at night, it's their regulation or their CQC rating, as it was. And so regulation plays such an important role. Of course, we want people to focus on this agenda because they have to. But it's also important that they understand the moral reasons for doing this, focusing on this agenda as well. Going back to the 10-year plan as well, if I may, I think it's a fantastic opportunity to tackle inequalities for patients, for communities, and for staff. Those 3 shifts towards community, towards prevention, towards digital, provide us with opportunities to make sure, from the patient perspective, that we don't leave anybody behind in terms of digital innovations. In terms of community and prevention, it will be critical. The success of the plan will depend upon the degree to which we are able to, as collectively, build and rebuild levels of trust with our communities and with our staff going forward as well. So it's really important that we focus on those aspects as well. There's also a opportunity here, I believe, to reframe the ED&I health inequalities agendas, to make sure that they focus on evidence-based interventions that are data-driven, and that lead to positive outcomes for patients, communities, and staff.
Absolutely. I want to come back to at the end, if I may, to a bit of a crystal ball and look forward. But before, because we've got Charlie here, we're able to talk about one of the cohorts of the workforce, of course, the medical profession. And just wanted to tarry on that briefly with you, some observations. Your national training survey came out, and there's some really interesting things in there, some shocking things. And I just wanted to give you the opportunity to share your hope for the medical profession, because one of the stats which I found amazing was something like 39% of, I think, minority doctors were not confident enough to raise the issue around discrimination.
Yes, it is a problem, and it's not just doctors from ethnic minority backgrounds. Our national training survey asked a new question this year, which was actually about escalation of patient safety concerns, and about 1/5 of trainees said that at some point in the last year they'd been hesitant about escalating concerns. And we should worry about that, because that is a patient safety issue. But we also know that doctors from ethnic minority backgrounds, and particularly overseas trained doctors, face more challenges and difficulties, and are perhaps more apprehensive about raising concerns than others. And just briefly, if I may, I think one of the things we do need to be quite conscious of and careful about when we talk about the workforce of the future and the 10-year plan is really recognizing the diversity of the medical workforce we've got. And just on one specific point, about 40%, over 40% of doctors who are registered with us trained overseas. Outside the UK. And there is an absolutely kind of, laudable, reasonable aim within the 10-year plan to have more of a UK trained workforce in the future. It is, and indeed, if we're going to have a sustainable workforce, that's really important. But we need to recognise how reliant we are on that overseas trained workforce, and how difficult it can be for doctors who are coming into the UK from overseas to succeed. There are many barriers that are placed in their way. We know that doctors historically have faced real challenges in terms of getting the induction and the support they need. We've provided our own induction to doctors. About 55,000 have gone through that since we started our programme just over a decade ago. But we can see more of those doctors facing challenges in terms of referrals to the GMC, disciplinary processes by employers, ability to progress through education and training. And I guess one thing that I do think we all need to be quite careful about is how we talk about those ambitions in the 10-year plan, because
it's a fine dividing line, isn't it?
Well, it is, but we need to demonstrate that we value. I mean, those overseas doctors working in the NHS do a fantastic job. Let's be under no illusions. We depend absolutely on the diversity of the workforce. It is, as Habib said earlier, something we really should celebrate. But there is a danger in the narrative about UK trained doctors that we send a signal that somehow doctors who've trained overseas are less welcome, that they're not valued. And I think there are big risks in terms of both this agenda that we're talking about today, but there are also some, much shorter term risks in terms of if doctors don't feel welcomed. Remember, these are doctors who've moved countries to work before. They're very able to vote with their feet and leave the UK. And I think we need to be really conscious about how we create a narrative that is embracing, valuing and supporting and celebrating the diversity we have within the medical workforce, whilst also having mature conversations and narrative about how do we want the shape of that workforce to evolve in the future. And I think that's something incumbent on all of us to be really reflective and thoughtful about how we talk about those sorts of issues.
Absolutely. A couple of final points, if I may. There's been some very inspiring conversation here from each of you, regulators together. I just want to step back and think. We've had similar conversations, not maybe as strident before. I'm old enough to remember that there was a Race Relations Act in 1965, one in 1968, 1976, indirect discrimination. Stephen Lawrence was 1993, Macpherson Report, Equality Act 2010, WRES 2015. So this agenda's been around for a while, and I wanted to highlight from each of you, what can we do to make sure this conversation isn't happening again in 10 years' time? What are the pitfalls that we must avoid? Julian, I want to come to you, obviously, as a regulator and a very celebrated leader in the NHS. The EDI plan that came out in 2023 had a number of laudable action impact points, one of which was to eliminate the environment where bullying and discrimination could take place. And I'm not sure we've done that, but a couple of things that we've got to avoid, so to make sure that this does actually become a concrete reality.
Absolutely. I mean, I think that we still could and should do more to make sure that all leaders across health and care are fully attuned and committed to this agenda in terms of, I think about the learning, training, development that I've experienced in my career. I think about the deep understanding sometimes that is beneficial for leaders to then be able to drive meaningful change in their own organisations. And I think a lot of it is about making sure that we create a really positive opportunity for leaders across health and care to learn from one another, share the best practice and what they're doing. And actually, there are many good examples of how practical steps on recruitment, on development for emerging Black and ethnic minority leaders in organisations. There are some important moves in a number of places I've seen on the allyship programme. And there's a clear roadmap now that we have, which Habib mentioned earlier, we're using as an organisation, the commitment, I think, of every organisation to be anti-racist, to follow the 7 key steps. We have a framework, we have the evidence. I think that's a core leadership activity. So I'd emphasise that, and I think even more so in a society that's divided and riven by many controversies and challenges at the moment. I think it's vital in the work we do to deliver ultimately for our patients to tackle health inequalities that we're able to strengthen and deepen our commitment to everything we've discussed today.
Thank you for that. Habib, how do we, your comments on that, make sure we avoid these pitfalls that perhaps we've had in the past?
Absolutely. I think, Sohail, what makes me optimistic now is the fact that we are able to openly talk about racism. Julian talked about the 7 principles of anti-racism that we put out. I'll just talk about the very first principle because I think it's critical, and that principle is naming racism. In any part of life, in order to change something, you have to acknowledge that there's something to change. If there's no acknowledgement that racism exists, or racial inequity exists, then you will not be able to move from that first step to any demonstrable change. So naming racism, I think we've come a long way since the 1960s and the legislation in the 60s, 70s, even 2010 Equality Act. I think we are now acknowledging that actually we have a problem and that we need to do something about it. And what makes me optimistic is this seminal point, not just a plan, not just Julian's appointment at the CQC, but the willingness of the regulators to come together, to work together, to be on the same page with regards to taking this agenda forward in a meaningful way. So I'm grateful to Charlie and to Julian and the other regulators for demonstrating leadership in doing exactly that.
Absolutely. And Charlie, the research that the CQC commissioned for your roundtable back in June, one of the remedial actions that it pointed out was a point that you'd made earlier, but I'll let you amplify that, was to consciously celebrate diversity within the system.
Absolutely. And to your point about all of those things that have happened over the years, I think we are at a seminal point because I think too often in the past, when people have talked about this agenda, it's often got too much lip service and not enough action. And it's really welcome to hear Julian talking so much today about improvement. And I've heard Julian talk about a lot about that in the past. I think the job of regulators is to drive improvement in the system. But that isn't something that actually you've heard always from regulators, both professional and system regulators. And what that means in practice is a preparedness to roll our sleeves up, to work out what works, build that evidence base as Julian's described, but also put our muscle and our resource into the accompaniment and support that actually enables senior leaders not only to be told what they should do, but to be helped with that journey. And I get a real sense of a change in the way in which regulators are prepared to roll their sleeves up and get engaged in that agenda. I think the other point for me is around how we use our data and the way in which we assess performance. I think it is a really important point that we are prepared to hardwire this agenda into the way in which we judge performance, whether that's Julian judging the performance of employers, providers, systems, whether it's the GMC judging training environments for doctors, or the way in which we set standards for individual doctors. All of those things in isolation are really important. But if we do all of those things together with a common purpose, with a common set of principles underpinning them, we have the real power to affect change. And the prize here is patient safety. If we get this right, I mean, Habib absolutely rightly talked about the billions of pounds that we lose, but he also started with the point that the fundamental outcome here is about what job we need to do to improve patient safety, to drive better patient outcomes. And the burning platform is the fact that there isn't going to be billions and billions of extra pounds being spent in the NHS over the next period of time. The 10-year plan was clear. We will have a smaller overall workforce in 2035 than was previously projected. So there is a massive burning platform to make sure that we are really valuing supporting the entirety of our healthcare workforce. It's not just doctors, but all healthcare professionals. And we're only going to do that if we really lead this agenda. So I feel quite excited about where we are. I do think we're in a very different place than we've been at any time during my tenure in this job. And I think there is a real sense of collective commitment and determination to make change happen.
Absolutely. One final point. Paint a picture. We've talked about the pitfalls. You've done that now here, Charlie, with the patient-centric element. But take the bigger picture, perhaps Julian, Habib. What would the world look like if this actually did come into reality? Not just for patients, but perhaps for the whole community that the NHS serves. I'm thinking of the Leeds Anchor Network. Paint that picture of what 2035 might be for communities if this is really seriously tackled.
So I would hope that we'd see, first of all, much greater empowerment for all citizens in relation to their own health and care, and that reaches across all communities, and that there is the ability for people to feel really connected and supported to manage health issues, challenges, to be able to access support in their neighbourhoods, and for that in turn to develop a greater sense of cohesion amongst communities. I do believe that big public sector organisations in any town or city in this country have an additional responsibility to think about social cohesion, to think about how they can act as anchors, if you like, to reach into communities on employment, on good quality housing, on ensuring access to health and care services, leisure, green spaces, or transport. All of those things are connected. All of them, we know, contribute to the sort of wider determinants of health and care. So a lot of that is about connecting up policy, but actually acting locally. And I think the 10-year plan really does emphasise that. And the second thing I would hope is that we are just much more compassionate and kinder to one another as co-workers, as colleagues, and that we don't fear or act defensively when we're presented with clear evidence about inequalities, about the experience of people in the workplace, that we use it as a positive opportunity and welcome it. And that shift, I think, is one that is possible, but it does require many of the things we've described today.
Fun word with you, Habib.
I absolutely agree with Julian. Empowerment increases, increased levels of trust and confidence. Shifting of the dial in the data that we see. But the fundamental question is, what kind of society do we want to live in? It needs to be a society where people are able to engage with each other, able to celebrate their differences, and look at the positives in those differences, as opposed to looking at issues that are detrimental, not just to ethnic minority people, communities, and staff, but to all people as well. So in that sense, I'm very optimistic that we can make a difference this time, and that can lead to a better world that we can all live in 2035.
On that hopeful and inclusive note, and the example of the regulators uniting, Julian, Habib, Charlie, thank you very much for joining us again and sharing your candour and your wisdom.
Thank you.
It's been a pleasure. If you've enjoyed this episode of Voices of Care, please like, follow, or subscribe wherever you receive your podcasts. And if you want to learn more about how we're turning the dial on health and social care, please visit newcrosshealthcare.com/Voices of Care. In the meantime, I'm Sahel Mirza. Thank you very much for joining us today, and I look forward to seeing you on the next episode. I think that's what we call a wrap.